With ADPKD, we think about it as a systemic disease. It can affect not only the kidneys, with PKD or ADPKD also affect other organs. So it can cause cysts in other organs like the liver and the pancreas, but also it can cause other things like intracranial aneurysms.
Not everybody will have major liver manifestations of polycystic kidney disease. The mutations can cause cysts in both organs. Some patients come to see us when they have polycystic kidney and liver disease, and some patients with polycystic kidney disease have liver involvement. Some people have only liver involvement. And then I get involved in their care when they're starting to have complications or symptoms from the cysts. And the cysts can cause problems with function of the kidneys, and people can go into kidney failure, need kidney transplant. With the liver, that's not really the case, and the liver can be nearly completely replaced with cysts, but the function generally is pretty good.
Now, with polycystic liver disease, it's a manifestation of ADPKD, but also there's another entity called autosomal dominant polycystic liver disease, where the main phenotype or the main manifestation is the liver, and there's only few kidney cysts. The management is the same for the polycystic liver disease, whether it's caused by ADPKD or ADPLD. We don't usually do much unless there's symptoms. And so if there's low quality of life, a lot of symptoms that are caused by this enlargement of the liver, we try to consider different options based on how the anatomy of the liver is looking like.
The liver cysts themselves, unlike the kidney cysts, which tend to, over time, kind of take over the kidney and cause problems with function, the liver cysts are unlikely to do that. And so it's uncommon to have functional problems with the liver, but some patients have bleeding of the cysts, which causes pain, but is not otherwise dangerous. Some people get infections of the cysts that can require treatments with antibiotics or drainage of those cysts. And then most of the symptoms we see for people with the polycystic liver disease is related to the size. The liver can get really massive compared to normal. It can get 4 and 5 times the size it should be, takes up a lot of space in the abdomen, pushes on the lungs, pushes on the stomach, pushes on the intestines, so causes problems that way. When we're talking about the cysts in general, there's several ways to try to treat them, to try to create space, and it really, again, kind of comes down to the number, the position, and the overall kind of approach for the patient. And there's everything from very minimal invasive techniques like what we call aspiration of foam sclerotherapy that our interventional radiologists do, to surgical approaches where we go in and call fenestration, where we open some of the cysts and try to take out kind of the blister component of the wall.
With ADPKD, there's also other manifestations like having increased risk of developing an aneurysm in the brain vessel. So those are called intracranial, so inside the brain, aneurysm. Aneurysm, it's a kind of a sac or a pouch in the blood vessel.
So what are intracranial aneurysm? It's a small, weak spot on a vessel that makes a bubble because the arterial system is pressurized, and when you have a weak spot, it ends making a bubble. Having an aneurysm is no big deal, but having a ruptured aneurysm is a much bigger deal. Ruptured aneurysms are a neurological emergency. Patients with adult polycystic kidney disease have a higher frequency of aneurysm than the general population.
Now, when we have these aneurysms that are a little bit larger, there's a risk for these aneurysms to burst. And if these aneurysms burst, it can cause brain bleed. So subarachnoid hemorrhage or brain bleed can also cause significant and devastating complications, with high risk of death and disabilities. What we do in our clinic is if someone has high risk of developing aneurysms, and by high risk we mean if someone else in the family had a brain aneurysm, had a brain bleed, or had a sudden death, then these patients are considered at high risk, which means they have a lifelong risk of almost having these aneurysms around 22%. So 20 to 22% of patients with ADPKD who have another family member with a brain aneurysm, they are at risk of having brain aneurysms as well.
For screening, the best study is an MRA. In general, MRA without contrast, but it should cover the whole brain. Basically, it's the best study for screening. Alternatively, patients who cannot get an MRI for any reason, foreign body or something, CT angiogram would be an alternative.
And we do that as screening. So there's a chance that we don't see any aneurysm, And then if that's the case, then we repeat every 5 years. If they're at regular risk, which just having PKD, we do it every 10 years.
The outcomes are better and continues to get better and will continue to get better. And technology is serving us, as a great help. For example, for screening methods, nowadays you can screen with minimally invasive imaging. You don't need contrast. You have an MRA to screen aneurysm to know about them. The resolution for MRA continues to improve and get better and better.
The goal of this screening program is to intervene at the right moment. So if an aneurysm is a little bit larger, we know that it's at high risk to burst. So we want to go in and do some intervention to kind of stop the blood flow to that pouch of the blood vessel. It's important to do it with a multidisciplinary team and with a team that has done it before and understand what polycystic kidney disease is and what aneurysms are.